Hey, welcome everybody. Thank you for joining us today for our Medicare Cost Report webinar. My name is Julianne Kipple and I am a shareholder at Lutz, and I'm joined by Kirk, who is a healthcare director here at Lutz. And I like to call Kirk our cost report guru. So he'll be doing some of the presentation today, and we'll kind of switch back and forth today. The goal of the webinar today is to do some review reminders on the Medicare cost report, hopefully a good overview of those items that we would encourage you guys to look at, annually when you file your Medicare cost report. And we'll also talk about some various analysis you can do using the cost report as a tool, whether that's financially or operationally. A few reminders before we jump into the slides. We would encourage you guys, if you do have questions throughout the presentation, to please go ahead and enter those into the chat function. We will be monitoring those throughout the presentation, largely at the polling questions. We'll take some time to see if any questions come through, and we will try to address those the best that we can throughout the presentation. The webinar is also eligible for CPE, so you will see some polling questions throughout the presentation and also some instructions on how to obtain your certificate. Okay, so we'll start with a quick slide on cost reimbursement overview. So this is a summary for your inpatient and ancillary or outpatient departments on how essentially your cost per day or your cost to charge ratios are calculated, which goes into your overall settlement for your Medicare cost report. We're not going to spend a ton of time on this slide. You could attend a cost report training for an hour or more that goes through in depth on each of these different worksheet series and what they mean, which we can answer questions if there are questions that come up on specific functionalities of the cost report. But I think what we're trying to do here is give a higher level understanding of how all of those worksheets interrelate and how the overall settlement is calculated, which also turns to the operational piece and the analysis piece that we'll talk about in a few slides. So as a reminder, for inpatient and ancillary, your direct costs, which are the direct costs that you accumulate on your general ledger by cost report department, are what's accumulated in worksheet A. Then we go to what's called the worksheet B series, which is your overhead costs. So how I like to describe that is you take all of your non-revenue producing departments, so your administrative and general departments, and you allocate them down to your revenue producing hospital departments based on various statistical factors, which Kirk will discuss a little bit later in more detail, which essentially becomes your total department costs for those revenue producing departments at your facility. The difference between inpatient and outpatient here is you would take, on the inpatient side, your denominator would be the patient days, versus on the outpatient side where that would be your total revenues. And so that's really what's going to generate either your per diem costs, so the cost that you guys incurred to provide a day of care, or it's the cost to charge ratio, which essentially means for every dollar of charges generated, that cost to charge ratio would show you the cost that you incurred to generate that dollar of revenue. So it can be a useful tool, and we'll look at that in a little bit. Then on the worksheet S3 and D series, what they're going to do is say, okay, here's your Medicare days and revenue, and they take that into consideration, giving your per diem and cost to charge ratio to come up with your Medicare costs. And then your worksheet E series is where you enter in, really the payments that you receive throughout the year for your Medicare services. And then what's left is your receivable or payable due to Medicare or due from Medicare. So again, that's very high level. And we're going to kind of jump in before our next section on interim cost reports with a polling question. So our polling question today is, do you prepare a monthly interim cost report estimate? And then you choose yes or no. And this will kind of help guide our discussion here over the next couple of slides as well. Okay, so give you guys a few more seconds here to answer. Okay, so it looks like we're split pretty evenly from the results here. So it looks like half of the audience on today's call is preparing a Medicare cost report and half of them are not. And we'll kind of talk about the pros and cons here of, why maybe integrating an interim cost report template would be advantageous to those facilities that are not doing it now. Okay, so interim cost reports. So the why behind them, they can be not necessarily challenging, but it's obviously a project to get an interim cost report into place, either on a monthly or quarterly basis at a facility. But really the benefits of doing that is you can really help monitor cash flow, and that includes any interim requests and rate changes. So, what really the goal of those interim cost reports would be is hopefully at the end of the year, not only do you know if you have a receivable or a payable from a cash flow perspective, but hopefully similar to a tax return, you've been able to kind of manage that payable or receivable so that we're not talking massive dollar amounts flowing one direction or the other direction. That also can have an impact on your net income through contractual allowances. So one of the, unfortunately, some of the large audit adjustments that we may see for facilities relates to the contractual adjustments through this interim cost report. So it can be material, it can change month to month, and especially at year end, it's important to know from a cash flow and net income perspective where that settlement is sitting. It also gives you the ability to track operational changes throughout the year. So as an example, let's say that you've started a new service line, wound care or something like that throughout the year, and that's going to change your reimbursement throughout the year as well. So analyzing that, getting that into your cost report as soon as possible gives you, again, a better understanding of your cash flow and that overall settlement. And then that also gives you the ability to monitor and review matching changes through the year. And we'll talk about that in more detail. But as the facility, when you get to the end of your year, as we all know with the audit and the cost report, it can be a lot to work through. So having that interim template, I think, allows you to have more discussions throughout the year as to whether, you really are truly matching revenues and charges appropriately. Are there more opportunities potentially in the cost report by, maybe we break wound care out into a separate, cost report department and see what that reimbursement change is. So I think it just gives you the ability to have a better understanding of where you're sitting throughout the year and also analyze the cost report to help make reimbursement decisions. So the goal, again, of those interim cost reports, we would recommend trying to do those monthly. And that really would produce a journal entry to adjust contractuals on a monthly basis to show your net income, I think, a little bit more accurately on a month-to-month basis. Again, it helps you monitor your per diem costs and cost to charge ratios. And then it also gives you the ability to readily have available cost report data to send for interim requests. So at least once a year from your intermediary, you should be receiving, an interim request. And if you're doing these templates, that time to, comply with that interim request becomes easier, less time consuming, and hopefully more accurate for your facility. And you can also verify that the information that the intermediary is sending back to you for those interim settlements and rate changes are accurate and are working in your current year of operations. If they're using last year's cost report to set the interim, or it's just the operations of your current year are not consistent with where the interim settlement rate change is going, you can always submit an additional interim request to try to, again, manage that overall settlement or receivable throughout the year. How would be that there's various models that exist for interim cost reports. Sometimes the external auditor will have one that you can ask to use. If not, there's various models that do exist, whether in Excel or through a combination of Excel and then the cost report software. So part of having that interim cost report available, I think it adds to the ability for our facility to do more of an operational analysis using the cost report as a tool. If you have that interim template, it also allows you to run financial statement projections incorporating reimbursement changes. And we'll look at a couple of examples here in a few slides of some common scenarios or questions that we get asked about whether or not, if we change this at the facility, how is that going to look 2 or 3 years down the line, not only from an operational net income perspective, but from a reimbursement change perspective. So it becomes a very valuable tool to evaluate those types of decisions up front, accounting for changes in Medicare reimbursement. Which I think I kind of hit on number 2 conversation. And then the third bullet point there, review cost to charge ratios to identify outliers. So that goes back to, when you look at those cost to charge ratios, it is really a operational indicator, right, of how a particular cost report department is operating, right? So if you have $1 of charges, but it costed you $1.50 to generate that $1 of charge, that essentially is what that that Medicare cost to charge ratio is telling you. So when you look through your worksheet C listing of all your cost report departments and all the various cost to charge ratios, you can start to see those outliers, or maybe from one year to the next, a certain department's cost to charge ratio increased significantly. Those would be those type of red flags or indicators to go back and look at from an expense and revenues perspective to see what changed or if any changes could be made in the future. So here are some of the common questions that we would receive on the operational analysis tool incorporating the cost report. And that would be, what would happen to net income if we, reorganized or had a management agreement with a nursing home, especially for critical access hospitals. Those nursing homes are non-reimbursable cost centers. So a lot of that overhead cost does get pulled down to the nursing home. So depending on, the available options to a particular facility, what they're looking at for their agreements, we can run a projection using that cost report tool, or anyone can with that cost report tool, to see what would happen and how reimbursement would change if that nursing home was no longer on the Medicare cost report. Similar idea with retail pharmacy. The retail pharmacy is also a non-reimbursable department. So, running projections on how reimbursement would change if you, again, handled retail pharmacy in a different way. How would your net income change, or how would your reimbursement change if we added a particular service line? I think that's, again, going back to that wound care example. You could say, okay, here's the break even from an operational perspective, but what would happen to reimbursement? Should we break out that cost report department into a separate line? Having those type of discussions up front gives you guys the data to make the best decisions you can. And again, what would happen to our reimbursement if revenue or expenses drastically changed in a cost report department? So if you're going into the next year after completing budgeting and hey, expenses in pharmacy or expenses in therapy are going to be significantly higher, you can incorporate that reimbursement change into even your budgeting to understand, yes, that is going to increase, but your expenses in the department, your cost to charge ratios, and your reimbursement Medicare will also change. So hopefully helping you kind of add some additional reimbursement value to your budgeting process. A few more common questions that we receive on the interim or the cost report as an operational tool. What areas are we spending too much money in? So we discussed the cost to charge ratios. All of the cost to charge ratios and cost report data for hospitals is publicly available. So that's where you can start to kind of benchmark your facility and your cost to charge ratios to maybe some peers to see what their cost to charge ratios are looking like. If your cost to charge ratios are significantly higher than your peers or benchmarks, maybe there is a different way to tackle some of the operational challenges in that department. What would happen to reimbursement if we changed our ER contract? So whenever those ER contracts are up for renewal or revision, that's always important to kind of pull in your cost report preparer or analysis to understand how that may impact, again, your reimbursement throughout the year. And then new hospitals, or, if you're building a new hospital, you're renovating your hospital, or you're changing the existing use of your square footage, that again can have a material impact on your reimbursement. So again, would encourage those projections to happen up front before making decisions necessarily, if possible, I should say, on some of those changes, so that, again, you're seeing the full picture of how your financial reimbursement may change. And we'll talk about this in more detail, but if you changed your statistical allocations of that, if we remember the worksheet B series and how we allocate that overhead cost down to the revenue producing departments, what if we looked at those allocations differently or used a different base to allocate those overhead costs down? And that, again, can change your reimbursement quite a bit.
So I'll just add something here as Julianne's talking. Dare I say the cost report can be fun, depending on how you utilize it. It is absolutely a very useful tool, especially for critical access hospitals in the reimbursement area, given the fact that Medicare is such a huge payer and such a huge reimbursement line item on your cost report and on your ultimate financials. So utilizing the cost report just makes sense from that perspective. To plan all of those different things. And for those of us who enjoy using the cost report, I said it's a very useful tool and interesting to play with what if scenarios.
If you're ever wanting to talk cost report, call Kirk and he'll chat with you.
Happy to talk.
So, again, some other benefits of having like the interim cost report and doing these operational analysis using the cost report would be board education. That's a great tool to bring in some of those projections and say, hey, this is how it's working. This is what this decision would do. I think is helpful to just, if the board may not have that cost-based reimbursement background, that could be a good tool for strategic planning sessions. Can also assist in doing charge master updates and kind of your overall pricing strategy, and again, how that may impact reimbursement. And then just monitoring Medicare utilization throughout the year. So that's, of course, again, going to have a huge impact on your Medicare reimbursement. If your utilization goes down for Medicare, your reimbursement likely is going to go down. So the monitoring that throughout the year will just help you kind of project out what things are going to happen.
All right, so Julianne's had the fun part. I would generally say in that the cost report is a very useful tool. How can we use it? What are the best ways to utilize it? And all of those great things that just make sense for you as a hospital to do on an ongoing and interim basis and planning purposes. Some of the issues that I'm going to talk about here for the next little bit are more yearly kind of items and specific to the cost report filing. So for example, the CRNA, the reason we bring up CRNA right now is it is very timely as we are at the end of a calendar year. So we're here partway through the month of November. So for those of you that file a CRNA exception or file for cost reimbursement, if you have not done so and are not in the process of doing that, please do so. Ask us questions if you have any questions. But for CRNA can be reimbursed on a couple different ways. If you do not file further exception, you basically bill and get reimbursed on the fee schedule. If you file for the exception with the appropriate criteria, you get that exemption to the fee schedule and you get cost reimbursement, to Julianne's point, cost to charge ratio times your Medicare charges, and that's what you get reimbursed. There is a third way, if you will, for as opposed to the one way just being pure fee schedule, the second way being pure cost reimbursement. If you do not file further exception, you can do at least method 2 so that you could get cost reimbursement, or increased reimbursement for your outpatient services that you just wouldn't get just the plain fee schedule. So the qualifications, just hit on these very quickly. If you are not aware, you need to be qualified for the CRNA reimbursement at cost. You need to be geographically located in a rural area. You need to employ or contract with the CRNA. Total service hours furnished not to exceed basically 1 FTE. There are certain volume requirements, and those volume requirements have been set at 800 since seemingly beginning of time. And then the CRNA needs to agree in writing not to bill. And the reason that last one is important is because you don't want your CRNA billing for the trophies for Medicare services on a 1500 claim form. Meanwhile, you are also billing for those on a hospital claim form. So you want to have your ducks in a row and be coordinated with your billing efforts that way. So then again, that third way is kind of a blended way. For method 2, you can bill for inpatient, you'd bill on a CMS 1500 and get fee schedule reimbursement. On the outpatient, you'd bill on the UB and not get the cost reimbursement, but you would get fee schedule plus 15% in case, and this would be for those facilities who just can't seem to make it under the 800 surgical limit, or you have enough volume that you just can't get there. You have more than one FTE as far as CRNAs on staff, which is great for you. Hey, you know, you're providing a lot of services, you're doing a lot of surgeries, all those sorts of things. But instead of the method 2 option, if you will, at least enables you to get a little bit extra on the outpatient side, that extra 15% on top of the fee schedule, instead of just a pure fee schedule reimbursement. So again, I'll just say again, CRNA, so make sure that if you have not filed that, file it. So then moving on to bad debts. So bad debts, here's just kind of a summary screen of some things that you need to be aware of and need to be taking into account, doing policies and procedures, et cetera, before we get into some of the details. So the thing I'll say about Medicare bad debts is, and this is partially from the current environment, partially from my experience being on the MAC side, the FI side, if you are claiming bad debts, the first thing that Medicare is going to do, if they do any sort of analysis on your bad debts on the filed cost report, is ask you for a collection policy. We've seen an increased emphasis in bad debt analysis, desk review work, audit review work on cost reports, and the collection policy is just one of the things that they are immediately asking for. So first of all, it's important that you have a bad debt collection policy, bad debt policy. Then second is following it. So I'll say the only thing worse than not having a policy is having it and then just totally ignoring it. Because Medicare is going to assume if you have it, you are following it verbatim, word for word. And if you are not, it just raises questions in their eyes as far as what's going on in the organization. So then consistency from a bad debt perspective. Medicare wants to see the same collection effort for all payers. If you're sending Medicare bad debts to a collection agency, you need to send all bad debts to a collection agency. Now, that doesn't mean that you need to send bad debts to a collection agency just in general. If you can just have it in-house, but it needs to be a consistent effort between Medicare and non-Medicare. The caveat or thing I'll add to that is if you have ABC collection agency for Medicare and XYZ for non-Medicare, you can do that. But again, those collection agencies need to have the same type of collection effort on their side, not just the same collection effort in-house, but the same collection effort, externally for Medicare and non-Medicare. And then we'll get into the timing here in a little bit, but this has changed over the years, probably over the last 20, 30 years. This has changed dramatically as far as what Medicare is allowing from a bad debt perspective. Bad debts are only allowable when they are truly uncollectible. If you probably went back in time 20, 25 years, maybe, you used to be able to claim bad debts. And then if you collected on those bad debts sometime in the future, say Kirk was claimed as a Medicare bad debt, and then I gave you $100 this year, $100 next year, you just use that as a, if I pay quarterly, monthly, whatever have you, you would just net that against your claimed bad debts. Well, Medicare anymore only wants you to claim bad debts on the cost report when it is truly uncollectible and you're not bringing in any monies. And we'll get into a little bit more in detail on that. Also, from an audit trail perspective, I mentioned that MACs are auditing more, so you want to have an audit trail for any bad debts claimed. You want to claim them in the year written off. If you are a 630 provider, for example, I'll use the current time frame that we're in and looking at some cost reports. If you're a 630 2022 fiscal year end, and we're looking at doing the cost report, we don't want you to have written those bad debts off in at the end of July or beginning of August of 2022, and then try to submit them on the cost report. So it needs to be claimed in the year that it is written off. And then the 120-day deadline we'll get into in just a little bit. So again, I mentioned Medicare kind of clarified some reporting on Medicare bad debts, and that came out in the 2021 inpatient prospective payment system final rule. But it obviously affects all providers, not just PPS providers. So they basically, in this new rule, divided Medicare bad debts into 3 categories. And I don't know if that makes it easier or harder from a tracking perspective, but it is what it is. So we follow the rules. So basically they have 3 different categories. So the first category is for a non-indigent beneficiary. That's just a beneficiary is being determined to be categorically or medically indigent by a state Medicaid agency, so on and so forth. So that is the first category. Then we have probably the next 2 are more the common ones. Would be a dual eligible beneficiary, someone who is enrolled in both Medicare and Medicaid. And then the third category is indigent by the provider. And this is probably gets the most questions as far as charity care, bad debts, indigency, what's going on here, so on and so forth. So basically, if it's that category of a person who comes in, they're not eligible for Medicaid, but based on your internal policies and procedures, guidelines, have been determined to be indigent under the provider's method. And in that case, you need to follow, and again, this is one of those jaded things, but follow the Provider Reimbursement Manual 15.1, Chapter 3, Section 312, A through D. And I am not going to go into details on that right here. Bad debts. There is a lot on these slides. I am not going to hit everything on these. I'll hit some of the highlights, but please use these for reference purposes later. And we'll remind you at the end of the presentation, but the presentation will be sent out. So if you want to refer back to these or don't worry about taking a picture or scribbling notes, this will be sent out. So again, that first category, similar collection effort, mentioned that. Timely billing. They don't want you to wait too long after the patient is discharged. So basically that you're billing within a reasonable amount of time. And then again, towards the end, that third bullet point, in addition to the first billing, efforts must include other actions such as subsequent billings. So they don't want you to bill once and then not send any more bills out and then basically claim it as a bad debt. So it needs to be essentially a reasonable collection effort in that you are sending out bill number 1, bill number 2, bill number 3, and then what do you have going on? Do you do an internal collection effort where you have people calling patient or the beneficiary? Do you send out more than 3 letters? Do you send out other letters, et cetera, et cetera? But then the 120-day collection effort, and you'll see this is a common string throughout. But to be able to claim, it must claim a bad debt for Medicare on the cost report. It needs to be at least 120 days from the date of the initial bill to the write-off date for this category. And it starts over at each payment. So if you have somebody who is making $5 payments per month, for example, that 120 days starts over. So that's just an important item of note. So then again, I mentioned early in the common string thread, whatever, we're talking about collection agency, similar collection efforts. Accounts must be returned to the provider, not kept by the agency. So this basically goes into the CMS logic or their thought process in that Medicare bad debts are not allowable until they're truly uncollectible. If the debt is still collectible or the agency is still working on it, then it's not truly uncollectible. So that's why they don't want you claiming it on your cost report at that point. It's only claimable on the cost report when it is truly uncollectible. And then collection agency fees. They are only allowable if you have similar collection efforts. So from a MAC perspective, they come in and do an analysis of your bad debts and they see, again, hypothetically, that things are just a mess. You use one collection agency for Medicare and it is entirely different than what the non-Medicare collection effort is. And you've claimed $100,000 of bad debts on the cost report and you've spent $500,000 in collection agency fees, again, for example. They can not only reduce your bad debts and disallow your bad debts, if the collection agency fees are, if that is the scenario, they can also disallow collection agency fees. So then again, the documentation required, collection policy, you want to have an audit trail if you're claiming those and a beneficiary file that someone can go back. Because again, when they're looking at this from an audit perspective, looking at it 2-3 years after the cost report has been filed or after you claim those bad debts. So the dual eligibles, again, you must bill. This is the second category. So you have Medicare, Medicaid eligible. So you have to bill Medicaid is what Medicare is saying. And any amount that the state is obligated to pay cannot be claimed. So essentially they want you to bill, they want to get a remittance advice from the state, and they want you to keep that in your file, so on and so forth. So the documentation efforts are somewhat onerous to providers. But again, this is the most recent guidance from CMS that they are wanting to implement. So then we have the indigent beneficiary eligibility by the provider. And this is that third category. And this is where we get some questions on indigent, charity care, all those sorts of things. But this is kind of categories for cost reports beginning on or after 10/1/20, which, you know, we're sometime past that now. So then you need to apply the procedures from the provider reimbursement manual. And again, you can read all of those criteria, but it really comes down to following A, B, C, D, 1, 2, 3, 4, however you choose to look at it, having that in your policies and procedures and following those steps and guidelines when you are processing bad debts, processing your payments, those sorts of things. So again, the charity versus indigency, I kind of alluded to, you know, what is the difference between charity? What is indigency? I don't want to say the line can be gray. It really doesn't matter what you choose to call it. If you want to claim it on the cost report, it needs to fall into one of those 3 buckets mentioned, and you need to follow the collection requirements from Medicare. So then this might be perhaps more in Julianne's world, not just straight the accounting or not the cost reporting, but more the accounting. So Medicare is not only telling you what you need to do from a cost reporting perspective and all those rules that I was telling you just a second ago, but they've gotten into the accounting and how they want to see it on your GL and your trial balance, how you're recording that from a financial perspective. So when this came out, the first bullet point was probably a little bit more applicable than it is just now, but or the second one, excuse me. So for cost report periods beginning on or after 10/1/20, which we are currently in, bad debts, charity, and courtesy allowances represent a reduction in revenue. So that is how they want to see it. So for cost report periods beginning before that time, Medicare bad debts must not be written off to a contractual. They must be charged to an expense account. So that was a more common method of recording them at that point. And then lastly, we're back into current time for cost report periods beginning on or after 10/1/20. They must not be written off to a contractual allowance, but must be charged to an uncollectible receivables account that results in the reduction of revenue. So that's really from a financial perspective. It's not going to matter on your cost report. Those issues were handled above, but these are more the issues that are being dealt with from a financial perspective.
That's great to look at from an accounting perspective, understanding where those Medicare bad debts are going, an uncollectible receivables account. So it used to be kind of like if you had the Medicare debt, you had all the documentation, the GL side wasn't as important like Kirk said, but now it is.
And again, this is, if you've don't have a template, please feel free to reach out to us. This is just a limited template. This is not a full one by any means, but if you need a template, reach out to us and we can provide you a bad debt template. And then just lastly, from the bad debt side, I just want to reiterate that MACs are giving this more scrutiny. Pay attention to the timely billing. They have mentioned in recent education, so this is specific to WPS, but they tie out bad debts to PSNR and remittance advice. And some of the things that they're looking for is wrapping into bullet point number 4 there is that it's only for Part A bad debts that can be claimed on the cost report. It is not professional fees. So they are looking at both of those things kind of in conjunction, remittance advice, and to make sure that it is Part A bad debt only, and it's Part A deductibles and coinsurance only. I guess I didn't specifically mention that, but it's Part A deductibles and coinsurance only, and no professional fees are allowed.
Okay, and that's going to take us to our next polling question. And that polling question is, can you easily get a revenue and usage report from your EHR vendor? I'd be curious to see what the responses are there and how easily maybe that may be obtainable or not. So we'll give you guys a few seconds there. Any questions? Okay, so somewhat split there again. It looks like 60% of us are able to get that from the EHR vendor and 40% no. You know, oh, now we switched to 50-50. So, you know, that can be a really big pain point. We're going to switch here to matching of revenues and expenses on the cost report. So this is important overall when we talk about using those cost to charge ratios as operational analysis, whether you're a critical access hospital or not. If you want that to be accurate, it's important to match your revenues to where the expenses are and vice versa. It's a critical access hospital that can directly impact your reimbursement through those cost to charge ratios. So really the goal there is to record the expenses used to generate the revenue in the same department. And the method there would be, you know, getting that revenue code crosswalk set up. So typically what we would recommend doing is getting that revenue usage by department by revenue code. And that really is like the truth or something, I guess you could say, or important to have to do this analysis, but that gives you the ability to answer some of these questions. You know, are the expenses that you can see by rev code that are going into a specific cost report department really, you know, used to generate the correlating revenue in that department? Are you recording the expenses in the general ledger to the correct departments? And when's the last time it was reviewed? So hopefully like on an annual basis, that's at least, you know, you can run that revenue and usage report, find any mismatches and try to address them. At least when you're starting a new service line or have any major changes, that's really important. And again, it just, when you're going to prep your cost report, it's really important to have a good understanding of this matching so that you are accurately calculating your reimbursement. And there may be opportunities if something's not matched correctly, maybe it's hurting your reimbursement when you should be getting more.
And I'd say overall in this presentation, that's probably the single biggest to me. Overlying theory, principle, or whatever of the cost report is matching. It's just extremely important. Now it's one way or another. If you're mismatched, you can be shorting yourself, you know, money, or you can be overstating what your reimbursement should be. But that's why the matching is just really, to me, one of the most important principles of the cost report, and can cause a lot of headaches given changes in systems, so on and so forth, which I'll let Julianne kind of dig into a little bit here.
Yeah, no, exactly. And it's really important to have kind of your charge master rep that's working on your charge master from the revenue cycle perspective and your accounting side kind of put their heads together on this to make sure it's accurate. So these are just a few examples of revenue codes that we commonly see having some matching issues between various clients. So revenue code 270, which is like a supply type charge. Where is that revenue going? Should it be, is it a billable, medical supply? What is it? Should it be in a central supply or medical supply line? Where are those expenses? And then again, treatment room can get a little funky with the 760, 761. Where is that service being provided? Is it being provided in various locations? Where are the expenses and how do you match all of that up? And then we're turning to a big adjustment again for critical access hospitals, and I'll turn that over to Kirk.
So again, this is one of those hot button issues, if you will. Specifically, I know WPS talked semi-recently on one of their presentations that in addition to bad debts, physician compensation is a huge issue, and especially from a critical access hospital perspective. It drives a lot of things that you have going on, whether your physicians are, if you have a rural health clinic, then you have ER coverage, if they're being compensated with salary, if they're doing rounds, so on and so forth. You just have your physicians are doing a lot of different things. And with a few exceptions, which can be major exceptions, physician expenses are not allowed on the cost report. And I'll say with three basically general exceptions, that would be kind of your medical director, which is kind of mentioned there. And if you have someone as a medical director at your facility, it'd be best to have that listed, enumerated, however you're going to say, in a contractual type arrangement, and specifically noted so that the WPS, Novitas, whoever audits your cost report, that can easily be identified. And from a MAC perspective, the Part A time must be documented. So if they're not documented, or the time of the specific salary, say for example, $1,000 a month, $2,000 a month, $3,000 a month, if that's not specific noted and you just move some money, you will probably find yourself on the wrong side of an audit adjustment on the cost report. And then the thing that Medicare really digs into is the split. So if you have physician compensation, how are you splitting your professional and provider component time? And specifically this mention here, we're talking about treatment time, Part B. If you have on-call physicians, which, you know, pretty much who doesn't have an ER, right? And who doesn't have physicians covering the ER from an on-call perspective. There are about as many different on-call scenarios as critical access hospitals, but nonetheless, when the government is talking about splitting Part A and Part B time, and they want to know the Part B time that physicians are spending in the ER, they generally look at three components to that. And the time that the provider is seeing the patient is comprised of those three parts. You have chart review, right? So if you go into the ER, the physician probably looks at a chart or looks at some notes before he or she walks into the room. Then they have the actual visit with you in the ER, the patient in the ER. That's the second component. And then lastly, but certainly not leastly, because they are making this again a point of emphasis, is the notes. So they're charting after the fact. So they want that encounter with the patient to be the entirety of that encounter, not just the time that they went into the room. It's the entire encounter and everything surrounding the experience with that patient. Because if you don't split that time, Medicare can and will consider all of that time Part B. So again, we have the ER logs, which we have kind of an example later, but the ER logs are used to remove the Part B time and expense from the cost report. There's a couple different ways of tracking this. You can do actual, which basically would be tracking every single hour and patient coming in and out of the ER, or you can do a time study. And again, if you're doing a time study, I don't know that we have any specific huge examples of time study, but make sure you are following your accepted time study, that it has been submitted to the government, to WPS, Novitas, whatever the case might be, and that it is approved and that you're using the prescribed weeks that you requested. And again, the time that should be tracked is those three items that I mentioned before. But here's a quick example. By all means, not an all-inclusive or a required example, but essentially we're getting, if you go back in time, more commonly we would see ER logs, and it would just count basically the time that the patient went into the ER and the time they left the ER. Obviously, you are shorting yourself probably in that case, so we need to find somewhere in the middle. We don't want the entire time that Kirk is in the ER, perhaps, but we want more than the time that the doctor is just in the room with Kirk. So we're tracking that whole time, but not the entire time that Kirk is in the ER.
Perfect. Okay, and we'll switch to our next polling question, and this is also the instructions on how to receive CPE credit if you are interested in that. Very important polling question. Are you still listening to us? So hopefully we'll see some good responses there. If not, we know we need to work on a few things. So thank you guys.
We know that some of us get a little bit more excited about cost reports than others, so that's fair.
Awesome, thank you guys. So we're gonna switch to worksheet B, which again is that allocation of overhead costs using various statistical bases to allocate it out. So I'll let Kirk talk about simplified method.
Yeah, so simplified method is a different way of tracking overhead costs. Again, Jillian mentioned way back at the beginning of this presentation, you know, how you are reimbursed from a cost per day perspective or cost to charge ratio perspective. You're not reimbursed for your admin specifically. That admin gets allocated based on a cost accounting or cost allocation perspective. So there are the quote unquote normal allocation methods. And then if you choose to elect the simplified method, it is a method that CMS has to reduce the administrative burden basically for hospitals. And there are specific guidelines that you have to follow. It reduces the number of statistics that you need to track, so it's less administratively burdensome. And this is an interesting comment, but in the rule, it says it cannot result in an inappropriate shifting of costs. And then once elected, it must be used for no less than 3 years. So that's why for those facilities that we've done a simplified method analysis for and looked at and requested that, We basically want a trended data, meaning we're looking at 2-3 years at least to ensure that it's proper for them. But basically other strategies for viewing statistics. Again, this can be one of those fun things on the cost report. If you're looking at allocation methods, but for example, there's different ways that you can do things. So how are you allocating your equipment depreciation? Are you allocating using square footage or the actual depreciation for that department? And that can be, it can be impactful one way or the other to you as an organization. Say, for example, your radiology. Radiology might not be a high square footage area, perhaps, but if you have high dollar equipment, MRI machines, all your radiology equipment, your X-ray machines, et cetera, that's one example of those sorts of things. But you want to make sure that you are tracking things appropriately and in a manner that is advantageous to you. Housekeeping, are you using square footage versus a time study? And this is monitored throughout the year. So this is one of those things, again, Julianne mentioned doing templates and tracking things through the year so that you, if you're a 630 provider and you're working on the cost report now, and we ask, well, gee, what happened during fiscal 7/1/21 to 6/30/2022, and there were changes made in July of 2021. If we are not aware of those, your cost report preparer is not aware of those, and you haven't been keeping up on those on a monthly, quarterly, or semi-annual basis, it can be hard to remember what happened 15, 16 months ago. So those are the sorts of things that we request or ask that you monitor through the year. And it really is not just a request from us, it's prudent business that you're looking at those. What are your square footage changes, your relocations, some of those sorts of things, your organizational changes, because that can impact from a nursing admin perspective. Did you reorganize? Does your DON now organize or is it supervise various different departments than last year? Then again, this is just strategies, which we mentioned a little bit before. New services, new buildings, cost allocations. Do we want to fragment A&G? There are a lot of different scenarios that can go into that. What is the impact of electing simplified method? Again, I went into that before, but again, this can be part of that fun part of the cost report and figuring out what you're doing from a statistical perspective and what makes sense, what benefits you reimbursement wise. And again, so the most important thing too is if you're not only the analysis, but there are certain timeliness requirements as far as requesting changes. Requests must be made in writing to the MAC 90 days prior to the end of the cost reporting period. And then they need to approve that because obviously they have the option to deny those requests. But there is a certain time element in analyzing and requesting some of those changes.
Okay, and that takes us, I believe, to our last polling question, which is, do you know if you have a rural health clinic, if your cost per visit is over, I should say rural health clinic or an FQHC, is your cost per visit over your cap and the dollar amount of loss reimbursement? And we'll talk about that in a little bit more detail in the next couple of slides. So far we've had some responses, so it looks like we're trying to know on that, and so we can kind of chat on that here again over the next couple of slides. Okay, so rural health clinics, there is this rural health clinic cap that was put into place, and I want to say, gosh, what was it, 2020, 4/1 of 2020? Try to remember the exact date. It's been some time.
Some time, not years fly by. Yeah, recently.
Yeah, recently. But basically what that said is that you used to get paid your cost per visit, no matter what that was as a provider-based rural health clinic. Now they're going to say, okay, we looked at a specific year cost report and they set a cap on you moving forward, and that cap is only going to increase by like an inflation factor every year. So it's possible now that as a rural health clinic, you're not actually getting paid your costs if your cost per visit exceeds the cap that is in place for your facility. We again use those interim templates to estimate that loss of reimbursement. So we basically can compare to your current month, your year-to-date through the current month, like what that loss of reimbursement is. So we calculate cost per visit and we look at what that cap is and we tell you, hey, you're losing, maybe $50,000, $75,000 of reimbursement because of that rural health clinic cap. So then we recommend that you review those directly assigned costs for accuracy. We'd hate to see maybe an inaccurate expense getting coded in the rural health clinic that maybe is more facility-wide, that should be more on the hospital reimbursement side. get that reimbursement than hitting the cap in the rural health clinic and not getting any reimbursement. Obviously, that needs to be accurate, but it is a useful tool to make sure that you're reviewing that. Review FTEs and visit counts. Make sure that, you know, when you're doing that productivity limit, which we're talking about productivity standards and define those below, if your FTEs are wrong, you know, and you're inflating your FTEs, that can inflate your productivity standard and, you know, create that penalty for you, which again deflates your cost per visit. Moving to vaccines, again, for FQHCs and rural health clinics, you know, they will pay for the cost and the administrative time to provide vaccine, flu and COVID vaccine. Just to note, if that COVID vaccine was provided to you at no cost, you're not claiming the cost, you're only claiming the cost of the time to administer the vaccine. So it's just important, you know, that directly impacts your reimbursement on the cost report. You want to make sure you're tracking all of the vaccine expenses to purchase those that you can, and also accurately reflect the staff time it takes to administer those to get the reimbursement on that. So are you tracking who administers the vaccines? What's the estimated time per vaccine? I think we hit on capturing all the costs. You need that log of Medicare beneficiaries receiving the vaccines, and then reporting all of your vaccines administered. This is just a quick, we're talking about rural health clinics, we're talking about provider time studies on the ER side. This is just a quick example on the rural health clinic side of potentially where maybe each of those docs are spending their time. And we would hope if you have a rural health clinic, you know, doing some type of time study or log on where they're spending their time is very helpful, so that we make sure we're moving those costs around as needed on the cost report. We are just going to take a few minutes. We have about 8 minutes left. This just came out, so we wanted to add it in. It may not be necessarily cost report related, but this idea of the Rural Emergency Hospital or the REH, the final rules on that just got finalized earlier this month. Gosh, it is that time. Finalized. So it had been talked a lot about maybe over the last 6 to 9 months, but finally did get finalized. You know, this is the ability, you know, the REH overall is an option out there to evaluate, to see if it's right in your community, to see if it's right for your facility to operate versus being maybe a critical access hospital as an REH. There are resources out there to help facilities do that analysis. If that's something that you're interested in, we do have some resources at the end that you can look into further. But at high level, you know, the REH would provide emergency services, observation care with a caveat of the patient can only be there less than 24 hours. And you can provide additional outpatient services. That provider time would be effective January 1st, 23. Again, available to critical access hospitals or rural facilities with less than 50 beds. So the payment for REHs, if you're a critical access hospital looking at this, you would no longer get cost-based reimbursement, but you would get the OPPS payment rate plus a 5% additional payment plus a monthly facility payment of that $272,000. That monthly facility payment will increase by a hospital market-based percentage increase, you know, for inflation and other factors in future years. And an important clarification in the final rules is that REHs can operate rural health clinics. So again, if you're a critical access hospital looking at this model, you could still operate your rural health clinic and get that rural health clinic reimbursement. Conditions of participation, again, I think are going to be pretty similar to critical access hospitals, but you know, there are some conditions that you would want to review, obviously, before making this decision, to see if it's viable again in your facility to have that clinician on call at all times. Emergency department must be staffed 24 hours and 7 days a week. And then again, that annual per patient average length of stay cannot exceed 24 hours. So that's not to say you can't have one patient that does exceed it, but overall on a yearly average, they cannot exceed that 24-hour. There are some requirements to implement a quality assurance and performance improvement program, which I'll talk about quickly, and then infection prevention and control and stewardship program. So Again, those are just some conditions of participation, provider enrollment, also must be enrolled in Medicare. They're still kind of working through what that enrollment provision and process looks like, but they have kind of said in this final rule that instead of going through an initial enrollment application, you could just use the 855A, which is just a change of information application, which is going to be significantly less time than an initial enrollment. And then they're looking at certain, Stark laws and maybe some rural provider exceptions under this model to reduce barriers to care. This is just a quick update on the quality reporting that would be required. At this point, you just need to have an account, have a designated security official, and then they're looking at, future topics to kind of miss my G on that. So seeking comments on topics of interest for future rulemaking. So they're looking at, how do you incorporate, rural emergency department services, behavioral mental health, which I know is a key issue. So is maternity health and telehealth and health equity. So they're trying to take all of those into account under this new model. There's those other resources that I mentioned earlier. If you're interested in learning more, we're happy to, point you in the right direction and answer questions if you do have them on this REH model. And again, I think it's either the National Rural Health Association or there's more, programs out there to help facilitate and analyze this if it's something that you're looking at. So I think that brings us to our questions. And I know we're kind of a little short on time, but we have, maybe 5 minutes here. We're happy to stay on the call longer if there are particular questions that you guys want to ask. But do want to open it up to see if there's questions. And if there's not, or if you have a particular question that you want to email over to Kirk or myself or give us a call after the webinar, I'd be happy to walk through those with you. As a reminder for those that are on the call today, we'll send you a recording of the webinar along with the slides. That will also have our contact information in there. Awesome. And thank you guys. Again, we'll just kind of wait here if there's any questions. Otherwise, appreciate you joining us today and hope you have a great rest of the week.